Idiopathic intracranial hypertension unmasked. Nitrofurantoin as a potential etiological factor, a case study by Mariano Raceto Rubio, MD, PGY1, Shipra Patel, MD, PGY3, Hira Chaudhry, DO, PGY2, Brian Delgado, MD, PGY2, Fernando Carreras Calvo, MD, PGY2, and Adela Hernandez Martinez, MD. Introduction. Idiopathic intracranial hypertension is a rare neurological disorder characterized by elevated intracranial pressure that primarily affects overweight women of childbearing age, often leading to debilitating symptoms. The etiology of the disease and its sex-specific prevalence, as well as its pathophysiological relation with obesity, remains unknown. Previously, there have been reports about a possible association with the use of nitrofurantoin. Patient presentation. History of present illness. A 20-year-old Hispanic female patient with a past medical history of hypertension and prior right artery stenosis stent placement in 2013 was evaluated in our facility for persistent throbbing headaches over the last month, associated with nausea, vomiting, and photophobia. Initially, the headache exhibited improvement with prone position. The patient visited the emergency department twice in the past 3 weeks. On both occasions, cranial CT scans were within the normal limits. In the most recent visit a week ago, she was diagnosed with a urinary tract infection and nitrofurantoin was prescribed. During the last week, the patient reports a new onset of double vision and tinnitus. Physical examination showed an awake and oriented patient, overweight with a BMI of 26. She presented with bilateral cranial nerve 6 ophthalmoparesis and bilateral papilledema on fundoscopic exam. No other neurological alterations were found. Laboratory data showed CBC and BNP within normal limits. Lumbar puncture with high opening pressure of 400 mm and no signs of infection. Clinical course. The patient reported improvement of symptoms after lumbar puncture. Acetazolamide was initiated and she no longer experienced headaches but continued to present diplopia. Due to symptomatic improvement, she was discharged with a prescription of acetazolamide for 2 weeks and advised to follow up with neurology in the outpatient setting. Imaging, head CTA, MRI, MRA, and MRB with no acute abnormalities as you can see in both imaging. Discussion. The exact etiology of idiopathic intracranial hypertension remains elusive. It is thought to be associated with alteration in cerebrospinal fluid dynamics, including overproduction or impaired absorption of CSF. Although the condition is idiopathic, several risk factors have been identified, including antibiotic medication. Idiopathic intracranial hypertension presents with a range of symptoms, including severe throbbing headaches, which are typically more pronounced in the morning or when changing position. Patients may also experience blur or double vision, tinnitus, nausea, vomiting, neck pain, and dizziness. The severity of symptoms can vary among individuals. Early diagnosis and intervention are crucial in preventing vision loss and minimizing long-term complications. Although weight loss is fundamental in treating the underlying condition, acetazolamide is often initially used to lower ICP, relieving optic nerve pressure while allowing time for weight loss. The duration of treatment remains non-standardized and in most cases is guided by the patient's symptomatology. This patient experienced an exacerbation of symptoms after the initiation of nitrofurantoin. This medication has been reported as a potential etiological factor, however, the supporting evidence in the literature is limited. Conclusions. 1. Given the debilitating symptoms and the potential vision-threatening complication, a high index of suspicion and early treatment for idiopathic intracranial hypertension is required. 2. This case highlights the need for further investigation into the potential association between nitrofurantoin usage and the development of idiopathic intracranial hypertension. Thank you.